We're very excited to be here with Dr. Mohammad Zubairi today, who is a developmental pediatrician and an associate professor at McMaster University, and currently medical director for the McMaster Children's Hospital Autism Program. He's a member of the McMaster Autism Research Team. He's a chair of the Physicians of Ontario Neurodevelopmental Advocacy Network and a board member with Empowered Kids Ontario. Welcome, Dr. Zubairi.
Thank you for having me.
Thank you so much for being here today. One of the things that we really want to talk about is sort of your role as a developmental pediatrician specialist. What does that mean and what do you do?
So developmental pediatrics is a subspecialty of pediatrics, which means that I went to school first to train as a pediatrician, and then I did some additional training to work with kids who may present with a variety of different developmental or behavior concerns. And so that does require additional training. And as part of my clinical work right now, I will see kids, generally speaking, anywhere between 0 to 18 years of age. Typically, we're not seeing the kids that are very, very young, although the hope is that with the implementation of diagnostic hubs, that kids will come to us sooner and we'll be able to work with them more closely. But generally, I'll meet children in a clinical setting where I will be asked specifically, what could potentially be explaining this child's developmental delay. For instance, if there's a language issue or a social issue or an issue with walking, I'm specifically asked, is there a diagnosis behind that? And one of the diagnoses that we take into account as part of that is autism spectrum disorder. And so, I'll have an opportunity to meet lots of children, gather information from families, from teachers, from other allied health professionals that are working with them. And then I use that information and then my own observations of the child to come up with a conclusion. That's part of what we do in terms of our diagnostic work. And then oftentimes we'll follow these children to see kind of what other needs are arising as part of their day-to-day and what kind of things people are noticing in other environments like school or home or other activities that they might be participating in.
So in summary, Diagnostic Hubs what is its purpose and what does it do in terms of supporting families?
So diagnostic hubs are a relatively recent kind of entity that essentially were established to focus specifically on the diagnosis of autism, to really answer the question, does the child have autism or not? And that certain funding was earmarked specifically to support teams across the province to be able to do that in a way that in its original form is multidisciplinary, so that you're getting input on a child from multiple health professions that are working together to observe the child, gather information, and to then be able to answer the question, does the child have autism or not?
Okay. And in your opinion, as someone who has worked with diagnostic hubs, what is the effectiveness?
Yeah, I think what it's done is that it's tried to bring together the right set of people to help with answering the question, does the child have autism? So I think the momentum has shifted in the right direction to say, how can we come to an answer in a way that's going to then support the treatment of this child moving forward. What form it's taken across the province looks very differently. And I think that kind of has its advantages and disadvantages, and we can talk a little bit about that. But from my perspective, I think, it's brought together folks to really help answer a question. At the same time, I think it's also then perhaps valued down some of the other developmental diagnoses that we might think about. So for instance, global developmental delay or ADHD or isolated speech and language delay, because the focus is on one diagnosis. Why I bring that up is because if you go through this process of the diagnostic hub and you don't get a diagnosis of autism, then what that does is that it leads us to ask, well, what do we do about these children that aren't meeting criteria? Or perhaps there's a different explanation for them. How do we better support them? So it sort of creates a bit of a division in terms of the pathways. And we can, again, spend a little bit of time talking about that because I think that's one of the tensions in the field. So yeah.
And in terms of families. What do you hear? Because we've been speaking to families from the Black communities and South Asian communities. We've connected with agencies who are working to support these families. And we've been hearing a lot about the challenges that they face through diagnostic hubs. What are some things that you've been hearing from families?
I mean, I think if we take a really big step back, first and foremost, is that how commonly known is the concept of a diagnostic hub among families, right? And I think that has to be taken into account. Many places may not be publicly advertising that they're functioning as a diagnostic hub, although let me backtrack. So I think that many places may not be using the terminology of a diagnostic hub, but the reality is that that's how their teams are organized, right? And so first and foremost, I think one of the challenges for us is to say, what do we let families in the community know about this process in and of itself, right? And I think at the end of the day, a family will want to, if the family has questions or if other folks have questions about that child, they're gonna wanna know, what's the best explanation for the difficulties if they're at that stage, and then what to do to support them. Whether that happens through a diagnostic hub or some other form of funding probably doesn't matter to the family unless we do something explicit about it, right? And especially with all the funding that is earmarked and the processes that have developed around the diagnostic hub, we probably want to somewhat be more explicit around it. So, no family comes to me and says, we're here for a diagnostic hub appointment. Often what happens is that our agencies and the communities that are set up to do hub assessments will use that language with families, right? And so then, does that hold the potential to confuse a family in terms of, well, I just want to see somebody who's going to assess my kid or not? I think there's a risk there potentially in terms of how we use the language of what the hub is and what purpose the hub is serving.
And so do you think the way that the hub is organized, and so obviously communication is definitely something to work towards, but the way that it's organized, do you think that it's actually supporting families who do come from diverse ethnic and social and socioeconomic backgrounds? Yeah.
So here's the tension, I think. I think in principle, the answer would be yes. In practice, I think the challenge is that the concept behind the hub is meant to standardize the process by which we engage with families and by which we engage with children that are actually, our clients and our patients. Sometimes in that standardization process, what gets lost is the unique and individual needs of a family and a recognition and an understanding of where they're coming from. And that coming from can obviously be ethnocultural, right? That's one element. There's a number of other elements that we can think about, but I think what we often do is that, the hub is meant to kind of funnel as many kids through the system to get a diagnosis. And, logically speaking, it becomes very hard to personalize the experience for a family if what you're doing is you're constantly kind of chasing numbers. Right? And when you're chasing numbers, you're running into the risk of, yes, I have a child, I'm going to apply a certain set of rules, to come to a conclusion, but you might actually start missing out on the context. Although the intentionality is there, right? The intentionality is that, let's be holistic and multidisciplinary, but in practice, I think the pressures of the system make it difficult to do that.
Right. And so what are some of the diagnostic tools that are used when you're trying to answer this question?
Yeah. So, kind of just to backtrack, so autism spectrum disorder is a clinical diagnosis, which is a technical way of saying that ultimately you have to have enough evidence through all the information that you've gathered to apply to a set of criteria that are laid out that allow you to come to a conclusion to say this is autism spectrum disorder. As part of that, we will rely on tools to help inform the data that we have and the information that we have. So one of the most common tools, for example, that's used clinically and that has a lot of work around training and capacity building is something called the ADOS Autism Diagnostic Observation Schedule, and there's a second version of it now. And so that's a tool that's categorized as something that's semi-structured. So there's some set of prompts and presses that you kind of have to run through to basically interact with the child, and then there's a set of like kind of flexible ways to engage with the child as part of that. That's one example. Another tool is something called the CARS, which is the Childhood Autism Rating Scale, and essentially it's more of an observation of the child rather than a direct interaction with them, although there's elements of that as well. And again, there's different versions of all of these. There's something called the Autism Diagnostic Interview, which is exactly what it is. It's an interview where you communicate with the families and ask a whole set of questions. And all of these tools are categorized as diagnostic tools, but the outcome or the score that comes out of that isn't necessarily diagnostic in and of itself. You use that information to basically feed into whether or not you're meeting the criteria, right? And so it's useful information. Now, we run into scenarios where, for example, we'll get a referral and say, we think a child has autism, please do the ADOS. That's not how the ADOS is meant to be used, right? It's meant to be used as that we think the child has autism, please help us answer this question, and then we may do the ADOS if we feel that it's necessary, or we may not, or we might do some other tool. That's different from screening, which is often what happens at, in family physicians' offices or in general pediatricians' offices. And I can speak a little bit more about that later on, but ultimately that's kind of some of the tools that we're using that are classified as diagnostic tools, but they don't necessarily in and of themselves conclude that the diagnosis is autism. Does that make sense? Mm-hmm. Yeah.
But do you think that families coming in think that this is the tool that's going to tell them?
So it's interesting, right? Because I think it depends on what parents have read and what parents have understood of processes. And that can vary in terms of the experience of families that are representative of diverse backgrounds. So someone with a lot of English literacy may have been on a forum where they've read that my child was diagnosed and the diagnosing physician or psychologist used the ADOS. So they may come and ask us explicitly, are you going to do the ADOS? Or if you haven't done it, they might ask you, why didn't you do it? That may not be the case in terms of families that are coming to us who may not necessarily be as familiar with the system or have the necessary capital to understand, right? Like what are going to be the elements of that? The onus then falls on us to say, how do we inform families about all the pieces that are going to help inform our diagnostic assessment of the child through the hub, for instance.
And so in delivering these tools, what are some of your reflections in terms of their sort of cultural relevance, in terms of, does it do the job it's meant to do? And, does it take into consideration who your families are?
Yeah. I think it's an evolving conversation. I think we're recognizing a lot more that the tools that we have, for the most part, have been developed in a westernized, English-speaking, predominantly normed white population, right? Now, I think there's an increased recognition that we are ultimately, now seeing kids where the reference and the norms may actually be different. Given their respective backgrounds and stories and narratives and experiences across various cultural groups, for instance, right? And so there's things that we historically haven't taken into account explicitly, like potential differences in how children play or what they play with within their home environments, how they use facial expressions, how they use eye contact, what is their interaction like with adults? Is there a component of shyness or modesty that's encouraged within the community that child is from? I think we haven't done a good job necessarily taking those into account, partly because our tools that we have don't make us focus our explicit lens on that, right? Like there's some work that was done in the last 5 years that's looked at all the tools that are available for autism, both screening and diagnostic tools, and they created a checklist of, again, 17 or 18 items to identify how this tool would do as it relates to its application with culturally and linguistically diverse families. And for the majority of the tools, they actually kind of didn't pass the checklist. It didn't, right? Because there might be a brief mention of take the context into account for a child's family. You might take into account their culture, but that's not how the tools are designed, right? They're really designed to kind of say, okay, what objective evidence can we get out of this 45-minute interaction that's going to help us to understand what might be going on. Part of our history and how we ask questions will hopefully get into the context, but that doesn't get factored into the criteria either, right? So that's the other tension, is that at the same time that the autism spectrum is stretched, right? And that's a big shift that's happened in the last 10, 15 years. You start to ask the question, where do you draw the line? And then even more importantly, where do you draw the line when all of your tools have not necessarily been norm referenced with a diverse population, right?
So where are they coming from?
Yeah, right? And so I think part of it is exactly that. And I mean, there's a whole other set of considerations that we can take into account, but that's just some of my reflections on that.
And in terms of culture, because you've spoken about this, what do you think the role of culture is in the diagnostic journey?
Yeah, it's a huge question. So when we think about culture as one variable that can influence perceptions of diagnoses as a broad category, they can influence access, right, in terms of what might be believed, what a family or a community might believe to be typical or atypical. So in terms of when does something become a red flag, and when is a concern for a particular family. There can be concerns around the stigmatization as it relates to developmental diagnoses, impacts on the status, impacts on service access. And so there's, I think, a lot of variables that get taken into account when we think about culture. I think the most important one that I've been particularly kind of highlighting a lot is this idea that families will develop an understanding of families will understand development through a certain perspective. Yes. And that perspective may be influenced by who's around them. Are there other caretakers involved in the child's care, such as grandparents or extended family members? And so their ability to act on a developmental issue is subject to all of these other influences. And that, may reflect, I think, in a significant portion, the culture of the family, but we also have to keep in mind this kind of other tension that when we think culture across generation, there can be differences there as well. So what we might assume or consider or explore for the first generation of a family that is new to Canada, because that's kind of, I think, where we spend a lot of our energy, we may not be able to make the same conclusions or decisions if we're thinking second or third generation, right? And so people are studying this now, in terms of what's their understanding of kind of, intergenerational influence when it comes to understandings of development, right? Which is, again, a whole other space, but happy to talk about that later.
So just to go back to the ADOS, do you think that, because it's standardization, right? That's what we're going for. But because it's been norm referenced, right, to a certain population, do you think that ADOS is effective for BIPOC communities?
Yeah. I think, again, people are looking at this, right? And so there is a greater recognition that, effectiveness is an interesting term, right? Like when we think about maybe reframing the question and saying, can we gather information from the ADOS that's going to help us to come to the decision as to whether the child has autism or not? And I would say as a tool, it allows us to begin to explore some of that. So it's helpful keeping in mind its limitations, right? And I think the limitations are things that we have to become more explicit about. And I think, as diagnosticians, right, is to say, so one standard thing that kind of comes up is, for instance, there's a routine in the ADOS where children are exposed to a birthday party scene, right? And so many times people will ask the family, for instance, like, has your child been to a birthday, right? And then what's the implications of not having asked that question and then posing that to the child? A lot of the ADOS involves, for example, interaction with a stranger adult. And so what does that look like for a family where perhaps those types of interactions are not encouraged? And then similarly, play, right? There's structured play and there's unstructured play, you know, and so a lot of what we do in the ADOS is structured play with some level of prompting. And so again, what does that look like for a child? Right? Or for instance, now that I'm thinking out loud, you know, there's a picture where you show folks that are on a beach, which looks like a really nice island. And maybe, you know, if we think about the travel experiences of families, they may not have traveled to a place like that. There are other pictures that are offered as well. But again, who's reflected in those pictures? What experiences do they promote or not promote? I think these are the types of questions that we have to ask ourselves when interacting with children.
So one of our families from the Muslim community, you know, when they were going through this process, talked about, you know, how they were asked, does your child eat with a knife and fork? And, you know, she said, you know, she felt embarrassed as a parent because that's just not the type of meals, you know, culturally that we eat. I mean, I eat with my hands at home. And she said that she didn't feel like she could say that out loud. To say, like, because it felt like it was a reflection of her. So when parents are coming in and, you know, there's interactions and questions being asked, are there things that could be improved to be more culturally responsive?
I think we have to start going there. And what I mean by that is that let's have the conversation, right? And put forth, so if you take the feeding example, instead of asking the question, is your child using a knife or a fork, we might ask, what does a meal look like in your house, right? Or at mealtime, you know, what is your involvement versus what's the child is doing? And so we want to take into account that perhaps the knife and fork question is really helping us to answer some of the fine motor skills of a child. And so are there other ways that we can explore fine motor skills, right? And so I think the onus is on us as diagnosticians to reimagine and reconsider the ways in which we ask our questions so that we're sensitive to the diversity of experience, so that we're taking into account that, you know, on any given day, if we're meeting 5 or 6 or 7 families, they're going to each represent a very different experience. And so, you know, how is it that we're asking the question? And then what do we do with the information that comes to us? In some of my own research work, we've often found that cultural issues, kind of as a broad construct, come up when there is, you know, either, like, for example, a conflict, right? So a team is not necessarily seeing the same thing as the parent or the child it might be seeing. And so that then invokes culture, right? And I would argue that we want to actually think about invoking culture as an important variable much earlier on in the process, to be able to ask questions like, you know, what do you think is causing these difficulties that, you know, we're seeing and perhaps the school is seeing? Do you even think it's a problem? And if you don't, why? And explore that. And I don't know that our diagnostic processes and world allow us to do that well, because we're trained to think of there's a problem and let's try to fix the problem. And I think the hub would really benefit from, I think the hub would really benefit from actively taking that into account. And it does, because the natural kind of next step after a diagnosis is, you know, referrals to different care pathways. And that, I'm sure you've heard from many of the families what that looks like, right? So you've learned a lot about that, and there's a lot of nuance there that can be influenced from where our blind spots are. But I think if we, you know, at the forefront really say, you know, what are our gaps in how we work with families, taking into account what we've been talking about over the last, 15, 20 minutes is going to be really important.
Do you think that there's a space for community agencies like SAAAC, like SOACH, like the Black Parent Support Group? Do you think there are spaces for collaboration between diagnostic hubs and community agencies, like at the beginning of the process? And what might that look like?
Yeah, I think it's a great point. What we really need to think about is, what is our communication and understanding around some of the screening elements and understandings of typicality and atypicality when it comes to development at the pre-diagnostic level, right? And I always argue that, we have to be thinking constantly around how can we help families digest the information that we're providing them at any given moment in time. And information starts flowing to families well before they make it to the diagnostic hub. And so if we can focus some of our energies at the pre-diagnosis level by recognizing what are some of the considerations that are more explicit or specific to, say, the Black community or the South Asian community, that's where our learning can be. I personally don't claim to have, expertise in being able to support, being able to do that effectively, but I think we have to be open enough to learn and to recognize that there's going to be a lot of heterogeneity in the needs. But if we haven't asked about those, then we can't really help shape or form a journey that's going to be, specific to that family.
So would it be fair to say for diagnosticians to approach things with the lens of curiosity, willingness to learn?
Yeah, totally.
And we can maybe do that in collaboration with the families we're serving. And agencies that are, I think, sort of acting as a bridge, right, between diagnostic hubs. And so if you were speaking with a team of diagnosticians and you're looking at screening tools and reframing questions, where might you start? And thinking you have seven appointments that day, right? How would you talk to them about, getting into the space to see that family as an individual? And even though the process is meant to be standardized, what are some tips or tools that you may have used or you're thinking about that you would want to share?
That's a good point. I think what I say, and I said this before too, is that we have to create an opportunity to be able to go off script. And what I mean by that is that the diagnostic pathway, whether it's through the hub or through other settings, is a scripted process. And what I mean by that is that there's certain elements that take place. You gather information, you do your observations, you come to a conclusion. We have to be willing to find the time and the resource to be able to go off script, to understand what the unique circumstances of a particular family and community are. That could be us going off script as diagnosticians. It could also be engaging with folks that are, now categorized as cultural brokers, for instance. And working with them to basically collaborate in a way that allows us to understand the context that we may not otherwise have, right? Because otherwise our default will be, well, that's a difficult family or that's a difficult scenario, right? And so we put the onus on the family, whereas I think we need to shift and put the onus on ourselves and say, what are the pieces that we haven't gotten to? And so that would be the one thing that I would think about is creating, being able to go off script. And then the other thing I think is what you were getting at is that, let's show that curiosity. I think that's a great point. If we're not willing to learn, where a family is coming from in terms of their unique experience, then that's a piece of information that we've just missed, right? Or that we haven't taken into account in our process, especially given the subjectivity, right, to some degree, that there is in how we interpret development. I always make this case that the word autism doesn't exist in most languages. We have a far way to go in terms of information exchange and understanding, and how development is conceptualized is so variable. But we, you and I can chat right now, we may have a shared understanding of what it means to have autism. That may not be the case, and often is probably not the case when we're working with families and children that come from diverse backgrounds.
So if you can think about maybe a year from now, 5 years from now, what would you like to see the evolution of diagnostic hubs be as it pertains to racialized communities?
Yeah, that's a good question. I would say that we would have an infrastructure set up to be able to learn as much about the families ahead of time with the support and incorporation of folks that really understand those communities. And either that's going to happen by creating an infrastructure that allows folks that are working as cultural brokers with the family to gather the information that gets kind of channeled up collaboratively, so that by the time they come for a diagnostic assessment, there's this kind of shared understanding of why you're there, what purpose this is serving, and what this is going to mean for your child moving forward. I think that's huge. Now, one of the biggest challenges is often personnel and resource, but assuming that we have that, I would say that would be the best case scenario, where a lot of this work actually starts, pre-diagnosis, and that then we have the same kind of follow through post-diagnosis, which is huge, right? Because I think these are the two gaps. It's easy for me to meet a child and say, I think your child's got autism, and then it's like, see ya, right? And so what happened before is going to influence how that information gets taken up, and certainly what happens with that information moving forward is going to be dependent on what the supports are. So I think the diagnostic hubs really need to start to embed, in my opinion, a lot of this kind of cultural context consideration in a more explicit and deliberate manner.
I think what we've heard from the families is really this just not knowing what's going to happen, what is happening. And something that we've heard a lot from families, I think from particularly in the South Asian communities, is that they are given paperwork and they don't even know there was a diagnosis until they've gone to a friend, an agency, and they know about it the first time. So you started talking about that gap, the pre and the post. What are specific, like in the infrastructure, what specific things would you like to see?
Yeah, I think what I would love to see is a post-diagnosis digestion meeting, right? This idea that Dr. Zubairi or Dr. X made a diagnosis, and really having the opportunity to understand what that is. It does exist in some capacity, but again, it's not necessarily influenced with a cultural understanding, right? So if you've got someone from the dominant culture that's basically doing this follow-up meeting, there still is that gap in terms of the understanding and the implications of that. So I think embedding that within it becomes really important. I also think that, when we say families need time to be able to digest information, I think they need time, but they also need some level of added knowledge and support to be able to do that, right? And I think that's where we kind of lose that.
You don't know what to ask in the moment.
Exactly, right? So if you don't know what to ask in the moment, that is a reflection of, what have we missed along the way to facilitate good questions and answers, and what can we continue to support along the way to, be able to have families ask the questions that are going to be helpful to them, right? And there's obviously a common set of questions that come up. So we can start there, right? Like, what does this mean for me sharing this information with other family members? What does this mean for me sharing information with the school? Is my child ever going to talk? Will my child be independent? What do I have to think about in terms of their long-term future? Will they be in a relationship? When a child is 2 or 3, this is the type of information that a family is grappling with. And I'll be the first to admit we don't do a good job at answering those, because we want to maintain a certain amount of hope, but at the same time we've learned so much about autism over the last many decades that it's partly our responsibility to help equip that conversation. I've been told that on one side, there's a universal principle that every parent wants what's best for their child. I believe that, right? You want what's best for your child, but how that is achieved is going to look different. And if we assume that all looks the same, then I think we're running into exactly probably the scenarios that you've heard from families, right? Which I can't speak to because that's not my lived experience, but there's a certain assumption that what we do, when we do, as we do, as it relates to a diagnosis of autism, is exactly the same process. And that, I think, is, it's the biggest hurdle that, in my opinion, we have to cross. I don't have a good solution for it. There's these reflections that we have, and our intentionality can help, and being deliberate about some of this can help, but we still have a far way to go.
So one of the things that we heard from parents and agencies alike is this idea of collectivism. And often the medical models, diagnostic hubs included, it seems very individualistic. Standardized, but individualistic. And so what do you think this idea of collectivism, it takes a village, is the intentionality seems to be team-based, right? And maybe in practice that's not happening. So what is the role of collectivism?
Yeah, I think that the role of collectivism first and foremost is for folks that are involved in the diagnostic process as team members is to understand exactly that, right? Because if our entry point into the work that we do is an individualistic worldview, which is the dominant worldview in where we live in Canada, then I think we run the risk of coming at odds when we see that, right? And so I think part of our understanding of a child and family's context is to understand, who are those players in that child and family's life that will influence what happens next. And that's the collectivism piece, right? It also comes down to community providers and diagnosticians, but I think, the models are set up in a very fragmented way, right? And so what I do as a diagnostician happens within the context of my medical model. What happens in education is, an educational model, and then what happens for autism-specific therapy is an autism model. So to be frank, I think what we're discussing here is one piece of that puzzle, or one piece of that bigger picture where similar conversations have to be happening at the level of care delivery, at the level of education. And unless we can achieve that, I think achieving collectivism is going to be challenging because those conversations have to have in parallel.
Those were some of the things that we heard definitely from the agencies as well, this a more innovative approach. And especially now in this era of EDI, which is on the tip of everyone's tongue, organizations are pledging, education and healthcare and media. Do you think that we are sitting upon a precipice, that if change were to happen, now would be the time, and how would that happen?
Yeah, I think I want to be optimistic that the trends in the wider community will help influence this, and it's our lens. I think we want to move away from the application of EDI as a checklist, right? And so if we're going to do this as something we've checked off that it's been done and taken into account, I think we really run the risk of finding ourselves in a very similar situation 5 or 10 years from now. I think if we think about EDI and all these considerations as a continuum of issues and challenges and opportunities that can arise in how we deliver care, how we connect with families as humans, and how we support people as they move through their journeys, I think we have a better opportunity to succeed. Especially if we take into account the feedback that families are providing. I think the one positive trend that the discourse on EDI has led is that there's a lot of input from folks with lived experience. And I think this program is doing that, which is awesome. And so our responsibility is to really pay heed to that, not to generalize, because again, even within the Black community or the South Asian community, there's going to be lots of nuance, right? There's going to be lots of difference. So I think our hope would be is that we don't generalize as a result of that, but what families are telling us really needs to be taken into account in the policies that we establish, the decisions that we make, how we allocate funding, what we value. And I think that's me speaking from my administrative hat, recognizing that as a frontline clinicians, I see the effect of all of that. Right? And I'm sure you do as an educator, and SAAAC sees as a frontline provider. So we're at this kind of funny time, right? Mm-hmm. It's an interesting time because there's a lot of momentum, but we run the risk of repeating what we've done because we've sort of said, here's an indicator, check, let's move on. Right? And so I could spend another hour talking about cultural competence and all those things. That's my area of work, but we won't do that today. But anyways, that's
But at the micro level of cultural competence, what are some things that you would recommend to diagnostic hubs that we can start? There's the systems, and then there's the micro. that we can do. So what's feedback or tips that you might have?
Yeah, so in terms of, again, competence assumes that there are things that you can check off. So I think the first thing that you have to do is, as an institutional level, is really to move to, as an individual organization, to get a pulse on what diversity is represented within the folks that are providing care in your spaces, and what's their understanding and learnings of their own kind of biases, both conscious and unconscious, right? And there's a lot of work that's happened around that space. I think there's an opportunity for us to continue to explore that. What I would not want to do, though, is to send off an implicit bias test to a worker in your community or in your agency and then to leave it there. There has to be an opportunity, as I've said kind of through this, is that information has to be digested. There's difficult conversations that need to be had, and there needs to be input from families to say what has worked well and what has not worked well. And so I think every organization can do that, and to think beyond the checklist model. And to really fall into other constructs of acknowledging cultural humility, that there's a lot that we don't know. Let's be curious, let's learn together. Let's spill this over into our decision making, applying an EDI lens every time a decision is made. And what does that look like, and who facilitates that conversation? So I think there's opportunities there, make it a standing agenda item on your weekly meetings, right? To say, where were our blind spots, for instance, right? During this week, how can we gather where our blind spots were? And so I think if we do the combination of those things, we're gonna be in a much better place than if we're just doing these pieces of EDI, right? So there's lots of opportunity there.
Dr. Zubairi, thank you so much. This was a very insightful and thoughtful conversation. I think there's a lot for us to take away from this. Thank you.